I will be providing few opening remarks for today's session, and then we'll get started with the speakers. Next slide. Okay. So for today's session, as we said, the title of today's topic is Leaving No One Behind, Community Partnerships in Reducing Hepatitis Disparities. Can you go back one more slide, please? I just wanted to have acknowledged the partnerships that we have with the Coalition for Global Hepatitis Elimination and the Task Force for Global Health. It has been a great partnership, and this is our fourth effort in bringing topics that are relevant to our institute to all of you. And this session is going to really be unique, that is going to highlight research collaborations with community-based programs to reduce hepatitis disparities. Next slide. So I just wanted to give you a brief overview of what NIH's mission is. Mission is to really support minority health and health disparities research. And we define health disparities as having an adverse health outcome that can be attributed to social disadvantages that populations face, which could be due to result of discrimination, oppression, being underserved in healthcare settings. And the populations that are interest to us are populations in the United States that experience health disparities, which is poor health outcome compared to the other populations. So when we say populations with health disparities, what we mean are the racial ethnic minority populations that are categorized by the OMB directive. You may have seen the new OMB Directive 15 that came out. So these racial ethnic minority populations include American Indian or Alaska Native, Asians, Native Hawaiian or Pacific Islanders, Blacks or African American or Hispanic or Latinos. And this year, OMB included Middle Eastern or North African as one of the minority populations. In addition to those OMB categories, NIMHD is also interested in less privileged populations from lower socioeconomic status, rural population, sexual gender minorities, and populations with disabilities. So next slide, please. So you may have seen this research framework before, and NIMHD has been really promoting to use this framework that shows that health disparities is complex and is multifaceted. So focusing on one factor or one level may not be effective in reducing disparities. If you see on the left-hand side, we have a list of domains that influence health. And on the top panel, you will see different levels of influence from individual level to system or society level. And most of the research focuses in one of those boxes, if you see maybe at the individual level, looking at either biology or behavior. And those, just looking at those alone may not be sufficient in reducing disparities. So we have to be mindful and look at multiple factors at the structural level, at the system level. Multi-level research is what we like to encourage people to consider to reduce health disparities. Next slide, please. So just wanted to say why NIMHD is interested in this topic. So when we look at the data at the national level, if you see, this is a graph that depicts hepatitis prevalence disparities by demographics as reported by CDC. So at the national level, there is a huge disparity between different racial and ethnic minority populations. The top graph here shows that chronic hepatitis B, if you look at the graph, it's highest among Asian American, Native Hawaiian, and Pacific Islander, AA and HPI population compared to the other population. And this is about almost 11 times higher rate compared to whites. When you, and the acute hepatitis B has been reported to increase in Black population as well recently. And these infections could be due to a variety of causes, and it has been seen to be prevalent in foreign-born individuals, but the data is not very clear. The collection of data is not routinely done in terms of the country of origin in research. So that's something and that could be improved. The lower graph here shows the rates of hepatitis C in different populations. And you can see the chronic and also the acute HCV rates are highest among American Indian and Alaska Native populations. So there is a concern that these rates are so high in these populations compared to the other general populations. When you look at the mortality rates, they also show a similar trend. Data shows that for HPV, hepatitis B related deaths, A and HPI have 8.5 times higher rate compared to whites. And for hepatitis C death, it's 3 times higher in AIAN compared to whites. So that's the reason NIMHD is interested to understand what are some of the causes that are driving these disparities and why do they exist and how can we best address them. We know that hepatitis is preventable. We have vaccines available for Hep B. We have treatments available for hepatitis C. However, the uptake of these are very limited, and they are even more limited in underserved populations. For hepatitis B vaccine coverage, we see only about 23% uptake in various populations. And when you look at the HCV curable treatment data, only 40% of individuals infected with HCV are even aware of their infection. And 1/3 of the insured patients undergo treatment, and they are much lower in uninsured populations. So both of these hepatitis infections rates are something that NIMHD is trying to figure out how to address them, how to understand the causes of them, and how to eliminate them. And when you look at liver diseases and liver cancer burdens, they are also higher in racial ethnic minorities. Next slide, please. So this is a slide that shows that liver cancer mortality. This is a graph that shows the mortality rates. The incidence rates are also very similar to race ethnicity. I just wanted to point out that the top level, if you look at the green top line, that is for American Indian and Alaska Native, and that's the highest burden. And that could be due to a lot of different reasons, and we need to have a good understanding. Also wanted to point out that Latinos have also the highest liver cancer incidence, and among Mexican origin populations, it matters where you live. If you live in the southern part of Texas, that's where the rates are much higher. So we at NIMHD have been very interested in trying to promote research in these areas. Next slide, please. So this is a funding opportunity that NIMHD, along with National Cancer Institute, promoted in 2017 to understand the mechanisms of disparities in chronic liver disease and cancer. And this was a great success, a partnership with NCI, and this was reissued in 2020. We funded a few grants in this topic, and we would really like to see more people submit their applications to NIH to really understand what are some of the underlying mechanisms that are driving disparities. And we wanted to promote people to look at the social determinants of health because, as I said, the research is mainly focused on understanding maybe changes in the gene or behavior, changing screening patterns, but really combining different structural factors and social determinants of health is something we are interested in that may help us understand what drives the disparities in liver disease and liver cancer. So next slide, please. So we have some understanding of what are some of the causes. So we created this new funding opportunity announcement that came out just this year. And these are to promote research on interventions to reduce health disparities. And this is the title, Interventions to Address Disparities in Liver Disease and Liver Cancer, PAR 24-207. So this funding announcement NIMHD created in partnership with other institutes to really encourage researchers to submit applications on multi-level, multi-domain, community-engaged interventions to conduct in populations that experience health disparities in liver disease and in liver cancer. And some of the priorities are, as I mentioned, community-engaged intervention studies is of great interest to us because we know those have been very successful in some of our other programs at NIMHD, multi-level interventions to improve HPV and HCV screening and linkage to prevention and care from multiple marginalized populations are of great interest to us. Then intervention strategies promoting HPV vaccination, promoting HCV treatment, uptake, adherence, and completion to reduce disparities. All of these are of great interest to us. So please take a look at that. And if you're interested, do keep in touch with us. Next slide, please. So this is my last slide. So basically what this ties in with the theme of today's webinar, NIMHD encourages community partnership in research. We have an extramural division on community and population sciences. So we understand that if you want to make a difference in populations that experience health disparities, you have to partner with the communities where people live so that you can get the lived experience to address the unique needs of various communities in the US and address the health disparities. So equitable partnership is essential to the success of Hep B and Hep C reduction strategies. And so today's session is really timely because it focuses on highlighting examples of effective collaborations with community partners. What are some of the lessons learned and how these partnerships have been able to impact some of the Hep C and Hep B issues in the communities. So with that, I like to start with our first speaker.